This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Neurology, published in 2026, titled Health-Related Quality of Life in Patients with Vestibular Schwannoma Managed with Observation, Stereotactic Radiosurgery, or Microsurgery, a systematic review and single-arm meta-analysis.
This is a topic that hits home for anyone in our field. Vestibular schwannomas, or VS, are the most prevalent tumors in the cerebellopontine angle, with an incidence of about 34 per million per year. Because they are generally benign and often small to medium-sized at presentation, our focus has shifted significantly toward management-related morbidity. We aren't just looking at tumor control anymore. We're looking at how these patients actually live their lives.
Exactly, Dr. Aris. The paper points out that while we have three established strategies, wait and scan, or W&S, stereotactic radiosurgery, SRS, and microsurgery, MS, the comparative effects on health-related quality of life, or HRQOL, have remained quite unclear. Previous reviews, like the one by Gowden in 2011 or Papatsaltsus in 2018, were often limited by small sample sizes or the use of generic instruments like the SF-36.
Right. Generic tools often miss the nuances of a CP angle pathology. This study specifically focused on the Penn Acoustic Neuroma Quality of Life Questionnaire, the PANQUAL. For our residents listening, why is the PANQUAL so vital here?
The PANQUAL was introduced in 2010 to capture the unique functional and psychosocial challenges these patients face. It looks at specific domains: hearing, balance, facial function, and anxiety. The authors of this meta-analysis wanted to synthesize the PANQUAL outcomes to see if one management strategy actually provides a superior quality of life over the others, at least 1 year after diagnosis or intervention.
And they conducted a massive search, PubMed and Embase, up to February 2025. They ended up with 16 studies covering 3,745 patients. That's a robust cohort. Let's get into the results. How did the total scores look across the three groups?
This is where it gets interesting. The pooled PANQUAL total scores were numerically different. For the wait and scan group, the score was 69.1. For stereotactic radiosurgery, it was 66.9. And for microsurgery, it was 61.3.
So, looking at those numbers, one might immediately assume that observation is best and surgery is the most detrimental to quality of life. But the authors dive much deeper into whether these differences are actually clinically meaningful.
Precisely. They apply what we call minimal clinically important differences, or MCIDs. When they looked at the between strategy differences, they found that none of them actually exceeded the established MCID thresholds. So while microsurgery had a lower numerical score than observation, that 7.8-point difference doesn't necessarily translate to a difference a patient would perceive as a change in their clinical state.
That's a crucial point for counseling patients. We often see patients who are terrified of the impact of surgery, but according to this data, the long-term HRQOL is broadly comparable, regardless of the path chosen. Now, let's break down the specific domains. Where were patients struggling the most?
Across all management strategies, the lowest scores, meaning the worst quality of life, were consistently in the hearing and energy domains.
That's consistent with what we see in clinic. Unilateral hearing loss is a major driver of disability, and the energy component often relates to the fatigue of vestibular compensation and the general psychosocial burden of a brain tumor diagnosis.
And on the flip side, the highest scores, the areas where patients felt they were doing best, were facial function and anxiety.
It's encouraging to see facial function scoring high. It suggests that across all modalities, including modern microsurgical techniques and precise SRS, we are doing a good job of preserving the facial nerve, which we know is a primary concern for patients. But I want to go back to the anxiety domain. You'd think wait and scan patients would be more anxious because they still have the tumor in their head.
You would think so, but the data showed that anxiety scores remained relatively high across the board, meaning anxiety wasn't as significant a burden as, say, the loss of hearing. However, the study does note that the diagnosis of VS itself is associated with reduced HRQOL, which can then be further impacted by the chosen management.
Let's talk about the heterogeneity of the studies. As a researcher, Alara, what did you make of the I-squared values?
They were high, over 75% across all analyses. This substantial heterogeneity means there's a lot of variation between the studies, likely due to different patient selection criteria, tumor sizes, and follow-up durations. It highlights a real need for standardized prospective studies. The authors actually mention that the lack of baseline measurements in many studies is a significant limitation. Without a pre-treatment pan-qual, it's hard to measure the true impact of the intervention versus the impact of the disease itself.
Right. If a patient starts with a very low HRQOL because they have a large tumor causing significant symptoms, their post-op score of 60 might actually represent an improvement, whereas for a small tumor patient, a 60 might represent a decline. This single-arm meta-analysis helps us see where patients end up, but the how they got there is still a bit of a black box.
Exactly. And the study also touched on the fact that many evaluations in the past were conducted on highly specific patient groups, which makes generalization difficult. By focusing only on unilateral sporadic VS and using the pan-qual, this paper tries to clean up that data.
So, for the residents and surgeons listening, when you are in the room with a patient who has a 1.5 centimeter vestibular schwannoma and they are weighing their options, how does this study change the conversation?
I think it allows us to provide reassurance. We can tell them that whether we watch it, radiate it, or remove it, their reported quality of life 1 year or more down the line is likely to be similar. We can move the conversation away from which treatment will ruin my life to which treatment is most appropriate for your specific tumor characteristics and personal goals.
It also emphasizes that we need to address hearing and energy levels more proactively. If those are the domains where patients consistently score lowest, we should be looking at hearing rehabilitation and perhaps vestibular therapy or counseling for fatigue, regardless of the treatment modality.
Absolutely. The authors conclude that while numerical differences exist, like the weight and scan group having that higher score of 69.1 compared to microsurgery 61.3, these are not clinically meaningful according to the MCID. The broadly comparable nature of these outcomes is the key takeaway.
It's a call for international collaboration too. To really overcome that 75% heterogeneity, we need multi-center prospective trials using the same tools, like the pan-qual, at the same time intervals.
And the study notes that the disease-specific nature of the pan-qual is what makes this synthesis possible. It captures the unique psychosocial challenges, the balance issues, the facial function, that a general SF36 survey just blurs over.
Well, this has been a very enlightening look at the state of VS management in 2026. The shift toward patient-reported outcomes is clearly the future of neurosurgical research.
It really is. It's not just about the MRI. It's about the patient.
Thank you, Dr. Alara, for breaking down the Prugen et al. Study. And thanks to our listeners for joining us on the Neurosurgery Hub podcast. Keep an eye on those pan-qual scores in your own practice, and we'll see you next time.
See you next time.